So this is going to be the recording for chapter 39, which is over nutrition. It also shouldn't take too long, just about 30 to 45 minutes. We are going to be covering what nutritional problems are, what can cause them, and then what we do about them as healthcare providers. So first and foremost, normal nutrition is important for energy, growth, and maintaining and repairing body tissues. It's very important for our patients that are in the hospital or in long-term care facilities, whether it's acute or chronic conditions, nutrition is required. And to recover properly from acute disorders and to decrease complications and exacerbations of chronic disorders, we need to optimize the nutrition that the patient is receiving. Major components of basic food groups includes macronutrients, which we talk about as in carbs, fats, and proteins, and then micronutrients, which are vitamins, minerals, and electrolytes. And then, of course, we need to be hydrated, and that requires water intake. Malnutrition is not just referring to undernutrition. It's any kind of abnormal nutrition, so that can be a deficit, excess, or any kind of imbalance of essential nutrients. However, when we say malnutrition in our regular routine language, we do usually mean undernutrition. Contributing factors to malnutrition states are socioeconomic factors that can certainly affect a patient's access to healthy foods, their financial status, whether they can afford healthy foods or food period. Physical illness can certainly affect how we are able to consume food. Incomplete diets related to the aforementioned reasons. If a patient is in a situation of neglect or abuse, they may not be receiving adequate nutrition. And then certain drugs and nutrients interact with each other and can inhibit the absorption of certain nutrients. So that can also lead to issues. And then conditions that increase a patient's risk for malnutrition: alcoholism, dementia, depression, decreased mobility, drugs with anti-nutrient or catabolic properties, meaning that they prevent the adequate breakdown or absorption of nutrients, excessive dieting, anorexia or bulimia, so types of eating disorders, hypermetabolism conditions. Those would be some of our endocrine disorders like hyperthyroidism, for example, stress, dialysis, diarrhea, wounds, swallowing disorders. So these all are pretty self-explanatory and are some of the more common reasons why we see people struggling with optimal nutrition. We can usually tell when a patient has malnutrition going on. It's pretty, especially if it's a chronic basis, it's pretty obvious. So their skin would be dry, scaly. They could have brittle nails, brittle hair, hair loss, rashes. Their mouth may show signs of dehydration, so crusting and ulcerations, changes in the pattern of their tongue. Their muscles may be decreased in mass. They may have muscle weakness. They may have mental changes in terms of their central nervous system due to the lack of appropriate nutrition. And then, so those are some of the more common findings. If you want a full kind of comprehensive list of assessment findings, Table 39.7 does a good job summarizing those. And then this shows Table 39.8. So sometimes we don't even realize that we're assessing nutrition in our patients. There's so many different things that go into this. Lab data is super useful in telling us a patient's ability to eat properly. So glucose, electrolytes, their lipid profile, BUN and creatinine for their kidney function, and albumin and prealbumin, which we're actually going to talk about later in this PowerPoint. Diet history: what is their ability to chew and swallow without aspirating? Do they have any changes in appetite or taste? Our older gerontologic population of patients have a lot of issues with this, just with normal pathophysiologic changes that they experience as they age. And so sometimes we have to get pretty creative with how we encourage those patients to eat a well-balanced diet. Health history, of course, what kind of conditions do they have at baseline that can prevent them from eating? Do they have any mental disorders that's preventing them from getting adequate nutrition? Of course, objectively, we can get their height and weight, their body mass index, which is not incredibly reliable for multiple reasons. So we're not going to focus too much on that. Any kind of recent weight gain or weight loss. How do they look? What's their overall appearance? Do they have adequate muscle mass and strength? What's their dental and oral health like? And then what is their functional status? This can also go back to some of those patients who have any kind of like chronic illness, stroke patients, traumatic brain injury patients, spinal cord injury patients, older adults who may have, like rheumatoid arthritis or dementia. All these things can decrease their ability to be able to feed themselves, to perform activities of daily living, to promote adequate nutrition. They may not be able to hold on to a fork even to be able to feed themselves. So lots of different components go into assessing a patient's ability to intake adequate nutrition. So nursing diagnoses we see commonly related to malnutrition, imbalanced nutrition, less than body requirements related to decreased access to, ingestion or digestion or absorption of food. And that can be related to anorexia, other eating disorders, dysphagia, increased metabolic needs, etc. Some of those things we've already talked about. Feeding self-care deficit related to decreased strength and endurance, fatigue and apathy. Deficient fluid volume related to factors affecting access to or absorption of fluids. Risk for impaired skin integrity related to poor nutritional state. So part of the Braden scale, which is a scale used to assess a patient's risk for pressure ulcers and other skin breakdown, is actually assesses their nutritional intake. So a poor nutritional overall state can increase a patient's risk of having impaired skin integrity. And then non-compliance, maybe, for whatever reason, they have an altered perception of adequate nutrition, they have a lack of motivation, or their lifestyle or socioeconomic status is incompatible with being able to optimally intake adequate nutrition. So again, that just kind of re-summarizes what we've gone over already. The goals of care related to nutrition are to help patients achieve an appropriate weight, consume a specified number of calories per day on an individualized diet, and have no adverse consequences related to malnutrition or nutritional therapies. So we do definitely want to individualize a patient's education related to nutrition, because if we're giving them options that don't culturally fit with their preferences, that if we're telling them a bunch of expensive foods that they can't afford, then we're just setting them up for failure. They're not going to be compliant with our education that we're providing them. So we need to really get an understanding of what they have access to, where close grocery stores are, how to read nutrition labels, different things like that to optimize what they put in their body to the best of their ability in whatever life situation that they're currently in. Some of those things, some of the educational things we can give to our patients, My Plate, which is kind of over here to the left, showing a general proportion of what your food should be. So half of it should be fruits and vegetables, and then the other half grains and proteins. The dietary guidelines for Americans, these can be Googled very easily. How to read nutrition facts on food labels to promote healthy nutrition. We definitely, at bare minimum, want to teach patients to avoid oversized portions, which can be very difficult in the American culture and society, because most food that we order is provided to us in an oversized portion. but we definitely want to hit home with how important it is to not overeat. Drink water instead of sugary drinks. Compare sodium in foods and go for the one that has less sodium. Of course, like we said, make half your plate fruits and vegetables if possible, and then balance calories. If a patient, for whatever reason, cannot meet adequate nutritional intake and related to like a chronic or acute disorder, then we have to provide the nutrition for them. If the patient has a functional, intact GI tract, then we can feed them through their GI tract. So these patients can require enteral nutrition, which is nutrition through the GI tract, because of an acute issue, like they just had a stroke or they are intubated in the ICU. So of course they can't eat, they are intubated. So we have to feed them while they're in this acute illness. Patients who have a traumatic brain injury may chronically require a G-tube in order to feed themselves because they don't have the neurologic capability or the cognitive capability to be able to feed themselves. So lots of different reasons can go into getting some kind of GI tube placed. Listed on this slide are some common ones that we insert: an orogastric tube, a nasogastric tube, a nasointestinal tube. So just like the name describes, it's telling you where the tube's inserted and where it ends. So an orogastric tube is inserted through the oral cavity or the mouth, and it ends in the stomach. Nasogastric starts in the nair or the nose and ends in the stomach. Nasointestinal, same thing, except it ends in the small intestine. A gastrostomy tube is what I'm sure a lot of you guys are familiar with in some of those long-term rehab and care facilities. So those can be placed surgically, radiologically, or endoscopically. So these different surgically, of course, means it was done in OR. Radiologically or endoscopically means it can be done like at bedside or in the endoscopy suite, excuse me. But what this is saying is there's an opening to the stomach. So it's literally a tube that is on the abdominal cavity at the stomach. A jejunostomy tube is in the jejunum of the small intestine, and that is placed in order to decrease a patient's risk of aspiration. A G tube still puts a patient at risk for aspiration, but the J tube is so much further down in the GI tract that there's a much lower risk of aspiration. And a gastrojejunostomy tube, allows for simultaneous gastric decompression as well as feeding. So when we have a GJ tube, the G tube is oftentimes hooked up to suction to allow for decompression of gastric fluids and acid buildup, while still being able to feed the patient through the J tube part. So the proximal end is the gastric part, while the distal end is the J tube part. So you can do both.